Thanks everybody for being here. I am Justin Ryder. I'm going to be speaking on behalf of Alan Browne, who fell ill and couldn't make it. My goal is to give you a U.S. perspective in 2 slides, so if I can do that, we're really good. I have a disclosure. We both have disclosures. So to give you a brief overview of the U.S. perspective from behavioral therapy perspective, I felt that it was wise to use the U.S. Preventative Service Task Force guidelines, which were recently published in JAMA in 2007, to just give a brief overview of where we are in terms of both screening and how we view using these interventions and the outcomes that we could potentially get. So the guidelines are pretty dense, so I just want to highlight a few points. That these guidelines are for children and adolescents 6 years and older, and for individuals at the BMI percentile of 95th and above, using CDC growth charts for age and sex. And that they came to the conclusion after doing all of their analysis based on all of the randomized controlled trials. So the U.S. Preventative Service Task Force only uses randomized controlled trials for their evidence base, so that's something to keep in mind, that comprehensive intensive behavioral interventions must have greater than 26 contact hours in 1 calendar year, so 12 months, that result in weight loss. That was their recommendation on the number of contact hours that need to be achieved for successful intervention. And we'll come back to that in a moment. Dr. Kelly will address this in more detail in a little bit, but the evidence regarding pharmacotherapy is inadequate. So if we look at what these recommendations mean in a little bit further from an interventional perspective, they should be group sessions coupled with individual sessions. Some should be parent only, some should be child only, and some should be family sessions. So really encompassing every multifactorial component in a way that you could tackle the individual along with the family dynamic. And when necessary, refer to a specialty clinical setting. This should not probably be conducted in the primary pediatric setting. These sessions should focus on healthy eating, safe exercise, reading food labels, basic education, as well as stimulus control, so trying to limit and avoid tempting foods, screen time, productive goal setting, as well as self-monitoring when people are misbehaving. And so the way that they came to these guidelines is they looked at interventions of different intensities. Now remember, these could only be randomized controlled trials, so we have a limited number of trials, and their recommendation is in this range right here, highlighted in red, 26 to 51 hours per week. It's only based on 7 trials though, so less than 500 total participants. So one thing that we can definitely say for sure is we need to build a larger evidence base. There's much larger evidence base if we use observational trials, but the standard of evidence for the U.S. Preventative Services Task Force is only randomized controlled trials. And in the intervention group, if they achieve this 26 to 51 hours, you can see a mean BMI Z-score reduction of 0.1 to 0.6, somewhere in that range. But the challenge with using that as our metric is that this is based on CDC growth charts. And so the Z-score really actually shouldn't apply to the US metrics. And so it was one of the major flaws of this publication. They were attacked on it a little bit. But if we break it, and then if we break this out and we look at the different interventional groups, preschoolers, elementary school students, and adolescents, you can see that the majority of these children actually gain weight on these interventions. So that is a challenge. And if we go to maybe lower standards of evidence, lower standard for the intensity of interventions needed, 6 to 25 hours, you can see that the adolescent group actually performs better with lower contact time. And so I think that's a really good segue into our next speaker, who's going to talk a little bit more about that contact time.
Thank you very much, Justin. I'd like to say thank you for being invited as well in this very important discussion. I will contribute with non-randomized control studies. I will control with the lessons learned from observatory studies. I'm a clinician, a pediatrician, and we have conducted probably something between 25 to 30 studies within the last 10 years, showing very consistently in all these studies, which I think is a finding in itself, 25, 35 studies, that we reduce the degree of obesity in 62 to 85, 90% of the children. We use 4.5 to 5 hours per child per year. We also, at the same time, achieve to reduce the degree of hypertension, steatosis, dyslipidemia. We also improve quality of life. We also improve body self-esteem. We also reduce appetite, and we also reduce the degree of bullying these children has been suffering from. So these studies have been studied in approximately 3,000 patients at the hospitals, not only our hospital, but another hospital reproducing the exact same results, showing 74% decreases, 74% of the children reducing their degree of obesity, but also in 8 municipalities across Denmark with 1,000 children, showing exactly the same, 74% of the children reducing their degree of obesity, as well as improving quality of life and decreasing the degree of hypertension, the degree of elevated blood pressure. So I'm just here, as you can say, as an hopefully inspirational way of thinking. The reason why I think we have achieved these results is that we look upon obesity as a disease and thereby prioritize obesity as any other chronic disease. As a pediatrician, and you meet asthma, and as you meet diabetes, you prioritize it. You give it the best possible service. That's one thing. The second thing we really need to appreciate here is the fat mass regulation that has not been spoken about before now, but fat mass is not just something that is going up or going down. It is actively preserved and fought for by the body. So when you try to achieve weight loss, we have very complex physiological processes happening within the body in order to counter weight loss, and we need to actually take that into account. So this is family-based programs in the hospitals, in the municipalities across Denmark, with the use of approximately 5 hours per patient per year. So I hope that could be inspirational, and I am certainly acknowledging the need of a controlled trial that we're trying to establish as well. I think this is what I would like to say. So I think, Justin, we maybe have a little bit discussion because we had a little meeting yesterday, and we thought, what should we discuss in 15 minutes? Europe and America. Quite a big task to try to do. So we actually focused a little bit about the time usage, because Justin just said something about before, 26 to 51 hours, approximating 33 hours per child per year, per patient per year, which in my perspective is unobtainable, especially in a country from you're coming from. I'm coming from a little dollhouse called Denmark, which is pretty small and small distances, but you're coming from a country with much more ethnicity, geographic challenges and so on. So I think we should maybe focus a little bit in a few last minutes.
Yeah. And I actually totally agree that the number of contact hours recommended by the U.S. Preventative Service Task Force is not only impractical, but it's infeasible within the clinical setting that they're wanting it to be delivered in. So it recommended that this be delivered in specialty care clinics. So these are clinics that are inundated with hundreds, if not thousands, of obese children every year. And 26 contact hours, even at the minimum bar for that, that is one session of an hour every other week. For most families, it's impractical. For most clinicians, there's just no way that that could ever happen. And so the recommendation itself is nice, but it's not ever going to be implemented feasibly within clinical practice.
I think that Louise Els rightfully pointed towards the need of understanding social inequality. And in America, the ethnicity, what I know of, is really tremendous challenges. So we really need to focus very, very directly upon how we can understand obesity better, because in my perspective, we do not understand obesity well enough yet. We know obesity, actually not obesity, but the fat mass is actually beneficial. The fat mass is beneficial during growth and development, but at some point that we are not aware about, it goes from being beneficial into being like a pathological disturbance. We know very little about that. So we should focus very much about what obesity really is. And I usually use diabetes as an example, how to think. Diabetes found out that insulin is important. So they actually found out the pancreas, insulin, glucose uptake in the muscle, and that by that scientific rigor, they actually managed to produce some pretty good diabetes treatment within the last nearly 100 years. I would think we should copy the way of thinking.
Yeah, I agree. So the other thing I was going to mention is if we look at non-randomized controlled trials, there's a study that's going to be published here, hopefully within the next couple of months, from specialty weight management clinics in the United States. It's a group, it's a consortium called POWER, which is all tertiary pediatric weight management clinics. They deal with the specialty treatment of obese and severely obese children and adolescents. It's 30 sites across the United States, so there is a diverse sample of both SES, race, ethnicity, and also delivery methods. In this sample, we have about 6,000 children, and I can tell you the results are quite disappointing. That this is our best care clinics in the U.S., 30 plus clinics, and the mean BMI reduction is virtually zero. There are about 10% of kids within those clinics that can achieve a clinically meaningful weight loss of 5% BMI reduction, but that should not be our standard. Our standard should be at the mean, how many kids are we actually achieving a clinically meaningful weight loss of, and we're just not doing a good job. And I can tell you the contact hours on average is about 5 in those groups, which is feasible and practical, but we're just not achieving or getting the results that we need.
Yes, if I have a final comment, I would like to say that I forgot that we also reduce the degree of obesity in the parents when the children come into treatment, and that our results are independent of socioeconomic status and the degree of obesity, which should be analyzed as well. I think the degree of obesity in the patient should be analyzed about how the treatment results is dependent upon that. I think that our measures of degree of weight losses are 0.22 in girls and 0.3 in boys, up to 12 months. And we have a dropout rate of 9.8% in 12 months and 22% in 2 years. So I just forgot these small measures. Yeah.
Yeah. We'll save the rest for the debate.
I think there's many questions. Thank you very much.